Good afternoon, everybody. Warm greetings from Rainbow Children's Hospital, and we welcome you for this weekly CME. The topic for today will be metabolic liver disease in children. So, for the next 45 minutes, I'll just discuss what is metabolic liver disease, what are all the conditions which can cause metabolic liver disease, and how to diagnose and how to treat. So, the term metabolic liver disease in children it is used for inborn errors of metabolism which involve liver and they either present as hepatomegaly, that is the child will have only an organomegaly, and or abnormal liver function test in the form of elevated serum transaminases or in the form of prolonged PT or APTT or hypoalbuminemia, etc. Now, as you all know, the food what we eat it contains carbohydrates, proteins, fats, etc. So they get digested and then it will be absorbed from the intestine. It will be taken into the liver, where there is lot of biochemical reactions that takes place. So the carbohydrate is converted into glucose and the protein is converted into amino acid, fat is converted into fatty acid, and from these glucose, amino acids and fatty acids finally the ATP is derived, and this ATP molecule is used as the energy currency for all the cells. And most of these biochemical reactions do take place in the liver, and therefore liver is rightly called as the internal chemical factory. And why we should know about metabolic liver disease? Metabolic liver disease it accounts for 13 to 43% of patients with liver cell failure, and nearly 5 to 20% of children, older children, they can have a presentation. So that is why it is very important for us to know about the metabolic liver disease. And how does these metabolic problems they affect the liver? One, either it causes the cholestasis, so there may be obstruction to the bile passages as that results in cholestasis, or because of the toxic chemical mediated injury it can result in an acute hepatocellular necrosis. So ultimately if we do the liver biopsy specimens, these will be the two important pathological findings what we normally expect, especially when we have a inborn error of metabolism presenting as a metabolic liver disease. Now, yes, these metabolic liver disease they can present to us in our routine office practice. For example, a small child can come to us with an abdomen distension where we see a big liver and a big spleen. Yes, if we do the liver function test, they may be high serum transaminases or whatever it is, or there may be prolonged PTT. So this can be coming presentation as an office practice, or they may present in a sick state to the ICU. For example, the child may present with an acute liver cell failure to the PICU. So the presentation can be either seen in the office practice or it can be seen in the intensive care setting. Now, having this, when one should suspect a metabolic liver disease in a given case? Yes, when there is a history of parental consanguinity. Two, when there is an unexplained sibling deaths. Three, when there is a positive family history of inborn errors of metabolism. Four, when the child has got a recurrent vomiting, failure to thrive, or a diarrhea. Child may present with seizures, encephalopathy, developmental delay, hypo or hypotonia, or they can have a presentation as jaundice, hepatomegaly with or without splenomegaly, the fulminant liver failure, and the coagulation abnormalities, or when there is a facial dysmorphism. So, whenever we see a child with the above features, we should suspect metabolic liver disease in the given setting. Now, what are the important things that one should ask in the history? So, for example, yes, a 10-month-old baby presents to us with an abdomen distension and mild jaundice. Now, how to proceed with this? First, in the antenatal history, we should always ask whether there is any history of acute fatty liver in the mother, or when the mother had pregnancy induced hypertension with HELP syndrome, that is maternal hemolysis, elevated liver enzymes, and low platelets. And if this mother had this history, then it is highly associated with very long chain acyl CoA dehydrogenase deficiency. Similarly, when there is a non-immune hydrops fetalis in the pregnancy, so one should always suspect in terms of Gaucher disease, Niemann-Pick disease, Barth syndrome, or a GM1 gangliosidosis. Similarly, in the history when there is development of symptoms after ingestion of fructose rich foods. For example, a child may be exclusively breastfed till 6 months of age. Then the parents would have introduced honey or fruit juices. Then the child starts developing symptoms of jaundice or vomiting or failure to thrive. Yes, always think in terms of a hereditary fructose intolerance. Right. Second, aversion to protein rich foods that may point towards a urea cycle disorder, whereas craving for protein rich foods and aversion to carbohydrates that may point towards citrine deficiency. So the dietary history help us to give a clue to specific types of inborn errors of metabolism. Now, what are the metabolic disorders that can cause basically liver disease? As you know, the food what we eat contains carbohydrate, protein, and fat. So the things which are involved in carbohydrate metabolism are galactosemia. Usually, galactosemia it is um, classical galactosemia due to galactose 1-phosphate uridyl transferase deficiency, or it may be due to isolated galactokinase deficiency. So the classical galactosemia may have its manifestation in the newborn period soon after the mother has started giving the baby the breastfeeds. Usually they present with jaundice, hepatomegaly, seizures, etc. And when we look into the eyes of the baby may have a cataract. Whereas if we look into the spectrum of galactosemia due to galactokinase deficiency, they are usually asymptomatic babies. They present to us only with cataract. So whenever we see a child with the congenital cataract, galactosemia should be considered as one of the differential diagnoses, and every effort should be taken to rule out underlying galactosemia in this child. The second carbohydrate disorder might be the hereditary fructose intolerance. Yes, a baby who was born breastfed till 6 months of age, complementary feeding initiated with sugar, honey containing foods. Yes, the child will have vomiting, failure to thrive that may point towards the diagnosis of a hereditary fructose intolerance. Similarly, the disorders which are concerned with the glycogen metabolism, that is the glycogen storage disorders, they can have varied clinical presentations of an organomegaly, early morning seizures, hypoglycemia, etc. The next thing will be the protein disorders. Protein disorders commonly is the tyrosinemia. Usually the tyrosinemia type 1, which presents in the newborn period, they are usually the sick babies. They present with jaundice, hepatomegaly, and acute liver failure will be the manifestation. It is usually the uncorrectable prothrombin time that may point towards the diagnosis of a tyrosinemia. And when we do the serum alpha fetoprotein levels, that will be very, very high. Similarly, the lipid storage disorders, which may be the Gaucher's or the Niemann-Pick disease, they are quite stable babies, but they have a very big liver or very big spleen. They can have a thrombocytopenia as the manifestation. Similarly, the mucopolysaccharidosis, when there is a facial dysmorphism that may have a Hurler phenotype or a Hunter phenotype. The minerals, which includes your Wilson disease and the hemochromatosis. The bile pigment disorders are Crigler-Najjar syndrome, Gilbert syndrome, and the Dubin-Johnson syndrome. The bile acid disorders. This is one of the upcoming entity in the metabolic liver disease, where the child will have jaundice, hepatomegaly, and the pruritus or the irritability in small babies that may point towards the diagnosis of a bile acid disorder. Of these two, or one is the PFIC, progressive familial intrahepatic cholestasis. Another may be the bile acid synthesis defect. The other disorders also can have a liver involvement, which may be due to this organic acidemias, urea cycle disorders. As we all know, the urea cycle operates in the liver. Fatty acid oxidation disorders, which mainly involves there is a hepatomegaly as well as there is elevation of the serum transaminases and the cystic fibrosis. So yes, now we have seen a baby. What are the basic investigations that one should ask when we are suspecting a metabolic liver disease? The first and foremost is going to be the liver function test. Again, conjugated hyperbilirubinemia, it points towards the diagnosis of a cholestatic disorder. Elevated serum transaminases, hypoalbuminemia, that is a chronic liver disease. GGTP, gamma glutamyl transpeptidase, which is compulsory to be included as a panel for the liver function test. The low or normal GGT includes the benign recurrent intrahepatic cholestasis syndromes, or it may be due to the progressive familial intrahepatic cholestatic disorders. The serum alkaline phosphatase, again, it gives a clue to the cholestasis. Prolonged prothrombin time, which is predominantly the synthetic function of the liver that tells there is a liver injury or not. Right, and here the normal or low GG levels are seen in progressive familial intrahepatic cholestasis type 1, type 2. Low levels are also seen in bile acid synthesis defects, and high GGT levels are seen in progressive familial intrahepatic cholestasis type 3. So the subtle marker, the GGT, it helps us to narrow down our differential diagnosis to a greater extent. Similarly, the uric acid, high levels of serum uric acid, it points towards Lesch-Nyhan syndrome, whereas the low level points towards molybdenum cofactor deficiency or a xanthan hypoxanthin disorder. Usually, the molybdenum cofactor deficiency presents in the newborn period. They will be presenting with the manifestation of difficult to control seizures. The ceruloplasmin, again, the normal value of serum ceruloplasmin is 20 to 40 milligram per deciliter. A value less than 10, it points towards more or less the diagnosis of a Wilson disease. The other investigations includes the bile acids. So bile acids are disproportionately increased in inherited bile salt transport defects, right? And whereas it is decreased in bile acid synthesis defect. Again, doing one serum bile acid, it helps to narrow down the cholestatic type of a metabolic liver disease to a greater extent. Serum iron and ferritin levels are increased in neonatal hemochromatosis. Lipid profile, abnormal lipid profile point towards glycogen storage disorders, Wallman disease, and the Niemann-Pick disease. CPK, so role of CPK in connection to the liver. Again, think in terms of either a fatty acid oxidation disorder, mitochondrial hepatopathies, or the glycogen storage disorder type 3. Again, alpha fetoprotein. The high alpha fetoprotein in the absence of hepatic malignancy is a sensitive marker for thyrosinemias. Urine, again, non-glucose reducing substance is very, very important. It is positive in case of galactosemia and fructosemia. So these are some of the basic investigations what we should ask when we are suspecting a child with a metabolic liver disease. So it starts with a liver function test. It goes to bile acids, ceruloplasmin, and specific enzymes. Next comes the imaging. So X-ray, adrenal calcification is seen in Wallman disease. Or when we see the epiphyseal stippling, it points towards the diagnosis of a Zellweger syndrome. Utility of ultrasound abdomen. Utility of ultrasound abdomen, yes, it's in a child with a chronic liver disease. It tells us about the liver architecture, the size of the liver, the presence of dilated portal veins, ascites, splenomegaly, etc. So it gives us a very important clue, especially to say whether the child has got a ascites or whether the child has got evidence of any cirrhosis or a portal hypertension. Bone marrow examination, yes, bone marrow examination, we are going to look for specifically for the storage cells that may be passed in case of Gaucher disease or a foamy cells that may be passed in terms of a Niemann-Pick disease and Wallman disease. And liver biopsy. Liver biopsy helps us to identify about the liver cirrhosis. It helps to identify the presence of cholestasis, etc. And when we come to the basic metabolic investigations, it is always the GALAC approach, which where G stands for glucose, A stands for ammonia, L stands for lactate, A stands for the acidosis or the ABGPH, and K stands for ketones in the urine. So the GALAC approach helps us to narrow down the differential diagnosis to a greater extent. In a given scenario, a child's sugar is low, there is hyperammonemia, elevated lactate, there is acidosis, and urine ketones are positive. That points towards straight away to the diagnosis of organic acidemia. Similarly, a child may have hypoglycemia. The ammonia levels may be normal to slightly elevated levels. Lactate may be positive. Acidosis may or may not be contributory, but absence of ketones in the urine points towards the diagnosis of a fatty acid oxidation disorder. Whereas in a given scenario, the glucose may be normal, there is hyperammonemia, lactate levels are normal, there is alkalosis, predominantly the response to alkalosis, and there is no ketones in the urine that may point towards the diagnosis of a urea cycle disorder. So the GALAC approach helps us to narrow down the broad IEM phenotypes into a simpler phenotypes. In addition to the above investigations, the other investigations that are routinely asked are plasma amino acids, acyl carnitine by dried blood spot technique, urine organic acids, urine succinyl acetone, which helps us to confirm the diagnosis of a tyrosinemia, urine orotic acid, especially it plays a very important role in narrowing down the various enzymes that are involved in the urea cycle disorders. Specific enzyme assays are very useful when we are dealing with the
lysosomal storage disorders, where here the predominant manifestation is the organomegaly and the developmental delay with or without dysmorphism. And finally comes the molecular gene test. So, having read about what is metabolic liver disease, what are the conditions or the IEMs that can present as metabolic liver disease, and one should suspect metabolic liver disease, and after suspecting, what are the initial investigations that one should ask for. So now we move on to the case scenarios. So this is a 4-month-old male baby who presents with seizures noted by parents at 5 a.m. So predominantly a beyond 3 months and early morning hypoglycemia. The baby has been fed overnight. On examination to the emergency room, he is actively seizing and he has got a moderate hepatomegaly. So the differential diagnosis at this stage, yes, one could be a sepsis, or second could be an inborn error of metabolism, or it could be just an isolated hypoglycemia, right? So the investigations are as follows. His plasma glucose is very low. Urine ketones are negative. His renal function test, liver function test, and blood counts are normal. This baby has got a high lactate. Normal lactate level is up to 2.4 millimoles per liter. 2.4 to 4 millimoles per liter are usually seen in cases of when there is a sepsis or a poor perfusion states. A slight elevation in lactate is acceptable, but any lactate more than 5 micromole per liter is definitely abnormal, and these babies, they have to be evaluated in detail further. This child's ammonia is normal and uric acid is very high. So the probable diagnosis is, yes, early morning hypoglycemia, hepatomegaly, right? Elevated lactate, elevated uric acid levels. There is no ketones in the urine. Probably this may fit into a GSD type 1. So how to proceed further? It is basically going with the liver biopsy, and now with the advent of the molecular gene testing being widely available, we can just go for the molecular gene testing also. So this is the liver biopsy picture of this baby, where one can see all the hepatocytes are enlarged and they are distended with glycogen. There is no fibrosis which could be seen in between the hepatocytes, and the PAS positive and the diastase positive. So this again fits into the prototype of GSD type 1. So how to treat this? Yes, frequent feeding, younger age group. So this baby is only 4 months old. So frequent feeding, avoiding prolonged fasting. Whereas in older children beyond 6 months of age, we can go for uncooked cornstarch. So the dose of uncooked cornstarch below 2 years is, it is 1.6 gram per kg every fourth hourly. And the main thing when we are advising, when we are prescribing cornstarch to the families, it is always uncooked cornstarch. So the mother has to take the cornstarch powder, put it in water, and then she has to give. It should not be cooked at any cost. And second thing is, we should tell the parents that they should not add sugar or salt to this uncooked cornstarch to improve the taste. No, that should not be done, right? And what is the dilution? Yes, 1 is to 2. So if they take 1 teaspoon of starch, they have to add 2 teaspoons of water. So that is the dilution where this child they have to take. And always when we are treating the child with a glycogen storage disorder, we should tell the family to avoid fructose, which is basically the honey and the fruit juices, sucrose, corn and table sugars, and lactose, dairy products, and the sorbitol. So this is a next scenario. This is a 5-year-old girl who presents with short stature, protuberant abdomen, and frequent falls during walking. On examination, she is very short, has moderate hepatosplenomegaly, and does proximal muscle weakness. And her labs are as follows. So plasma glucose is okay. Renal function test and blood counts are normal. There is marked elevation of SGOT and SGPT. Right? Normal reference range is about 10 to 40 units per liter, and the CPK level is also very high, 643 units per liter. So, girl child, abdomen distension, myopathy, elevated serum transaminases with elevated CPK. So, this may point towards the diagnosis of either a mitochondrial disorder or it could be a glycogen storage disorder, right? So here it points towards the diagnosis of GSD type 3. The reasons are being the hepatosplenomegaly, myopathy, and the elevated CPK and the serum transaminases. Now, Coming to the salient features of GSD, as all of us are aware of it, there are two types of glycogenosis. One is the hepatic glycogenosis, another is the muscle glycogenosis. Okay, and there are so many types other, and they have been described in the order of the when they were discovered. And this slide shows the cardinal features of various types of GSD. And the most important thing is going to be the uncooked cornstarch. That is most important. We have to take really pain and effort to tell to the families, otherwise the treatment is going to be not fruitful. So the points to remember when we are dealing with a child with the glycogen storage diseases: early morning drowsiness or seizures, there is no hepatomegaly, and postprandial there is a hyperglycemia, it is always a GSD 0, right? The myopathies are usually the GSD 5, 7, right? And the type 2 is the developmental delay with hypotonia and hypertrophic obstructive cardiomyopathy that points towards the diagnosis of a Pompe disease. Now, moving on to the next case, this is a 7-month-old female infant. She's first born to second-degree consanguineous parents, presented to us with a lower respiratory tract infection. On examination, this baby had a hepatosplenomegaly with the pallor and the hypotonia. Probing only, the parents gave the history of a developmental delay. Right? So, consanguinity, abdomen distension, favoring an organomegaly, hypotonia, right, with the respiratory tract infection. Always think in terms of a underlying metabolic disorder. So when we did the eye examination, it revealed a cherry red spot. So this is the cherry red spot which is seen at the macula. And when we did the bone marrow, it showed a large foamy cell. This is the cell, foamy cell, where the nucleus is almost pushed to the periphery. It points towards the diagnosis of a Niemann-Pick disease. So there is no definitive treatment available for Niemann-Pick disease as of now, and the treatment is only supportive. Right? And moving on to the next case, this is a 4-month-old baby who was instantly found to have hepatosplenomegaly during routine immunization visit to the clinic. Ultrasound showed hepatosplenomegaly with calcification of the adrenals. So here basically the diagnosis is established from the radiology department to the pediatric department. So there is a hepatosplenomegaly. Ultrasound was done as a part of evaluation of hepatosplenomegaly that picked up the calcification of both adrenal glands, and this is the X-ray that again showed calcification of both adrenal glands. So fitting into the diagnosis of a Wallman disease. Right? So there is a homozygous mutation which was heterozygous mutation in the LIPA gene that was favoring the diagnosis of a Wallman disease, and there is again the enzyme replacement therapy for this is basically the Sebilapase alpha. The treatment is very expensive, and this infant succumb for the disease. And this is a younger infant who presented with lethargy and poor feeding for 2 days. There was no history of fever, vomiting, or reduced urine output. On examination, she was afebrile, drowsy, and had hypotonia. Cardiopulmonary examination was normal, and there is only a moderate hepatomegaly. So the differential diagnosis that was entertained when we saw the baby was: 1, there was a sepsis; 2, this child presented to us in the peak summer months of May. So probably a dehydration fever; 3, or it could be underlying inborn error of metabolism. So the investigations revealed the normal blood counts and the negative CRP, so that ruled out the sepsis. Electrolytes were normal, and there was elevation in the serum transaminases. When we did the blood gas, it showed severe metabolic acidosis with very high lactate levels. The pH is only 7.11. The lactate is very high. And during the course of the hospital stay, this baby's lactate level it reached almost 20. Right? And the LP ratio was almost normal. So this was the differential diagnosis what we thought of. Probably it was a congenital lactic acidosis, or a pyruvate dehydrogenase complex deficiency, or a pyruvate carboxylase deficiency. So this baby was treated with IV fluids, and while the child was on IV fluids, the lactate levels kept on rising. So again, the rising lactate levels, especially when given dextrose containing fluids, it points towards the diagnosis of a pyruvate dehydrogenase complex deficiency rather than the pyruvate carboxylase deficiency. So for this baby, the molecular gene testing confirmed missense mutation in the exon 7 of PDHA1 gene, resulting in pyruvate dehydrogenase deficiency. The treatment is going to be different. because the pyruvate dehydrogenase complex deficiency is usually treated with a ketogenic diet where the seizures will be more, and these babies they cannot convert the glucose into this thing. So whereas pyruvate carboxylase deficiency, ketogenic diet is absolutely contraindicated. So that is the importance in narrowing down the diagnosis of a pyruvate metabolic disorder to dehydrogenase complex deficiency or a pyruvate carboxylase deficiency. And this baby was treated with dialysis, peritoneal dialysis, in view of the high lactate levels, right? And this child is almost now 1.5 years of age, doing very well with normal intellectual and cognitive function. And this is moving on to the next case. This is a 10-year-old boy who was second born of first degree consanguineous parents. He presented to us with jaundice for 8 months, pedal edema and abdomen distension for a month. There was no history of any GI bleed, altered sensorium, dystonia, dysarthria, drooling of saliva, or there was no history of any drug intake. But there was history of poor cholesterol performance, which was noted by the parents, especially the handwriting of this boy has started changing. And there was history of elder sibling death due to similar illness, so they were really worried. And on examination, he was ectic with bilateral pedal edema. He had KF and abdomen examination showed firm hepatomegaly, splenomegaly, and free fluid. All other systems were normal. So this is his investigations, which showed elevated serum transaminases, low serum ceruloplasmin, and ultrasound abdomen showing a hepatomegaly with altered echoes and splenomegaly. Endoscopy showed varices pointing towards the diagnosis of a portal hypertension, and 24-hour urine copper after deep penicillin challenge was 1127 international units. So all this fits into the diagnosis of a Wilson disease, and these are all the manifestations of Wilson disease. So the hepatic manifestations, which could be just an asymptomatic, if there is elevated serum transaminases, or it could be just an incidentally detected hepatosplenomegaly. Wilson can present in various forms as well as to the various departments. It can present with acute apparatus, it can present with chronic apparatus, it can present with cirrhosis with portal hypertension, it can present with acute liver failure or end-stage liver disease. Similarly, it can present to the hematology department only with the hemolytic anemia. It can present to the psychiatric department with dystonia, altered behavioral patterns, etc. It can present to the GE department with hepatitis. So where, or it can just present to the renal department with proteinuria, etc. So varying presentations of Wilson to various departments. So always it is the diagnosis is by having a high clinical suspicion. Right? So slit lamp examination, it is KFRN. Yes, of course, it is that gives a marker, and it is though characteristic of a neurovil disease. Sometimes we do see children with liver disease having a KFRN. Low serum ceruloplasmin, as I said earlier, the value below 10, it points towards the diagnosis of Wilson disease. However, value below 20, it says it is a low serum ceruloplasmin. There is increased copper, urinary copper, especially after a deep penicillin challenge. Liver biopsy, yes, they may showing a fatty degeneration of the liver, and sometimes stain for the copper may be positive. An increase in the copper content of the liver, yes. For this, we have to take the dry liver tissue, put it in the glutaraldehyde solution, and then we have to estimate the copper content by using the atomic absorption spectrophotometry. And so, as we all know, this is an autosomal recessive disorder because of the mutations in the ATP7B gene, right? And it is the most common metabolic liver disease in India. There is a treatment that is available for this metabolic liver disease, which is mainly the depenicillamine, and there is always an abnormal accumulation of copper in the various tissues. It can have a hepatic manifestation, neuro manifestation, or both. And the idea is screening of asymptomatic sepsis is very, very essential. And suspect Wilson disease in a child more than 3 years of age with presenting with metabolic liver disease. And this 14-year-old boy He was well till 13 years of age, but this boy had only intense itching for almost few months. There was no abdomen distension and he had intermittent pale stools. So because of itching, he consulted various dermatologists outside and his interest was very subtle, which was even very difficult for the parents to pick up. An abdomen examination had only a mild hepatomegaly, there is no splenomegaly and there is no ascites. So this is bilirubin, conjugate hyperbilirubinemia with low GGT levels. And bile acids were also normal. So ultrasound abdomen showed only a hepatomegaly. And so we thought of probably a um, bile acid synthesis defect, or it could be a progressive familial intrahepatic cholestasis. And this molecular gene testing came positive for mutation in the ATP8B1 gene, so which again points towards the diagnosis of a benign recurrent intrahepatic cholestasis. So this boy, for intense pruritus, we are treated with initially the ursodeoxycholic acid. That did not work for him, and subsequently this boy was treated with rifampicin. And with rifampicin, his pruritus is markedly reduced and he is asymptomatic now. The important aspect of knowing this benign recurrent intrahepatic cholestasis is this: it is always intermittent. They don't come, the symptoms do not persist for a long period of time. It is always the intermittent coming of pruritus as well as the jaundice. And whenever you treat with choleretics, the symptoms go back to normal. And the definitive treatment is yes, though it is said to be benign, and in some cases we have seen these children progressing into the liver failure. So it is a continuum of a progressive familial intrahepatic cholestasis. So in the last 30 minutes we have seen uh, what are the inborn errors of metabolism that can present with metabolic liver disease as the manifestation. Number two, when one should suspect metabolic liver disease in a given scenario. Three, what are the investigations that we should ask either in office practice or in the intensive care setting? Four, what are the various disorders on various subgroups that can present as metabolic liver disease, and few case scenarios pertaining to the same. Thank you.
So, there are any questions?
Well, in case lactate as a marker of pyruvate dehydratation or chronic stage, like the lactate done in blood gas, is it sufficient or should we send the lactate separately?
So, the lactate in blood gas gives us a clue. And if you have taken an arterial sample, it gives it is almost sufficient. Otherwise, we have to take a repeat lactate sample, which is a free flowing sample, and then we have to ask the lab people to analyze and give us the reports immediately. Otherwise, the arterial blood lactate itself, it gives a clue to the underlying diagnosis of either a pyruvate metabolism defects or it could be a fatty acid oxidation defects. A good arterial sample is sufficient, sir.
So when will we think of sending a expect a genetic diagnosis? Like is it mandatory to send genetic diagnosis for all metabolic errors, or basically with even if you get a GCMS TMS report itself, we can narrow down and treat? Or is it mandatory to confirm the genetic testing?
So the diagnosis of metabolic disorders is three components. One is from the history and the physical examination. Two, the biochemical, which includes the enzyme assays as well as the TMS or the GCMS samples. The third step is the molecular gene testing. And TMS is basically a screening test which points towards the diagnosis of a metabolic disorder. So it is always mandatory to have a molecular gene testing if available and feasible to have confirmatory disorders of the same, because the management includes not only treating about this patient, whereas for offering the counseling to the family members, and if they are planning for any future pregnancies, it is very essential for counseling. So the gene testing and the parents gene testing plays a very important role, especially when we are going to make the antenatal or the prenatal diagnosis.
Thank you, Dr. Ganesh. That was a wonderful presentation. Thank you, Dr. Ganesh. That was a wonderful presentation.
Yeah, thank you, thank you. Okay, if there are no more queries, I thank all my colleagues who have attended this meeting. Thank you very much.